Today we are going to talk about apex beat, right, which is also called left ventricular apical impulse. Left ventricular apical impulse, right? We will talk about what are the different types of apex beat, what are the underlying mechanisms in the different apex beats, different types of apex beats, and what are their clinical significance. But before really I go for normal apex beat, let me discuss normal apex beat. So what is normal apex beat? Normal apex beat is the lowermost and the outermost area of the precardium. This is the lowermost and the outermost area of precardium, where a definite cardiac impulse can be inspected or can be palpated. I will repeat it again, but before that you should know what is precardium. Precardium is that part of the anterior chest which is just in front of the heart, right? This area of the chest wall, anterior chest wall, which is just in front of the heart, this is called precardium. Now, what is apex beat? Apex beat is the outermost and the lowermost area of the precardium, right, where a definitive cardiac impulse can be palpated, right, or in a thin-chested person inspected, right? And this point where we can palpate it, it is also called point of maximal impulse. Remember that this is due to the left ventricular apex. When left ventricle contract, right, in the chest, when left ventricle contract, its apex moves forward and hit the chest wall. Where it hit the chest wall, that point is apex beat, right? That point is apex beat, right? Now, how do you know that what is the exact location of apex beat? Because when we communicate with each other, we need to tell the exact landmark that in a particular patient, where is the apex beat. In a normal person, normal adult person, right, apex beat is in mid-clavicular line and in fifth intercostal space. You know, from this angle of lowest, there is second intercostal space, then third, then fourth, then fifth. In most adult, in normal person, apex beat is located in the mid-clavicular line, in the fifth intercostal space, or slightly medial to the mid-clavicular line. And area of apex beat, area of normal apex beat should not be more than 3 centimeter. Usually they mention 2.5 to 3 centimeter, right? Now, and what it represents, systole or diastole? It represents systole, because on the contraction of the left ventricle, apex of the left ventricle is going to hit the precardium, right? Now, let me define it again. If someone asks you what is apex beat, you will say, on inspection or palpation of the precardium, the lowermost area and outermost area of the precardium where a definite cardiac impulse can be inspected or palpated, right, is apex beat, which should normally be in fifth intercostal space and with intersection of mid-clavicular line, and it shouldn't be more than 3 centimeter area. It shouldn't be palpable in more than one intercostal space. It should not be palpable in more than one intercostal space. If you can palpate apex beat in more than one intercostal space, then there is some pathology there, right? Secondly, in children which are less than 7 years, right, there it is slightly, because the heart is relatively horizontal in children, so apex beat is still in the midclavicular line, but not in the fifth intercostal space. Rather, in children which are less than 7 years of age, it is usually found in fourth intercostal space, right? Number one, heart is horizontal. Secondly, ribs are also angled differently. They are relatively horizontal, right? And this apex beat is normal apex beat. When you put your finger, right, if patient is supine, right, then it is easy to locate the fifth intercostal space and easy to locate the midclavicular line. But to palpate it better, or to palpate it in the best possible way, you need to turn the patient to the left, decubitus position, and you will best palpate it at the end of expiration. Why left decubitus position? Because that brings the heart more near to the chest. And why at the end of expiration? Actually, that relatively deflates the lungs and takes the pulmonary tissue away from the heart, so heart is more near to the chest, right? So what I'm saying, that apex beat is representing the point where at the onset of left ventricular systole, right, when left ventricle start contracting, left ventricular longitudinal fibers and circular fibers. There are two types of fibers. There are longitudinal fibers and there are circular fibers. When these two types of fibers contract, right, especially in very early time of systole, which is called isovolumetric contraction. Let me explain what is isovolumetric contraction. Let's suppose this is atrium and here is your left ventricle and here is your chest wall, right? It's like that. This is your chest wall. Now what really happens when here is aortic valve and here is mitral valve. When left ventricle start contracting, the pressure in the left ventricle goes up and first it will close mitral valve. But here pressure is almost 80 millimeter of mercury. So left ventricle, when starts contracting, intraventricular cavity pressure goes up, and as soon as it is more than 5 or 6 millimeter of mercury, it closes mitral valve. But still it keep on contracting, right? But pressure is less than aorta, so it is now contracting as a closed chamber because no more blood is coming and yet aortic valve is not open until it builds up enough pressure during contraction. Eventually it builds up enough pressure within left ventricular lumen that pressure is more than the pressure in the lumen of aorta, and then this will open. Now, before the aortic valve open, we say left ventricle were contracting as a closed chamber. That early phase of systole, that early phase of, for example, if we put time here, and this is systole and this is suppose diastolic time. Now, in early phase of systole, right, this phase, here mitral valve closes and here aortic valve open. During this time, left ventricle was contracting as a closed chamber. We call it that isovolumetric contraction. When there is isovolumetric contraction going on, let me more clearly close the. When left ventricular contraction is going on as a closed chamber, or there is isovolumetric contraction at very early stage of systole, what really happens? That longitudinal fiber start contracting from the base of the heart towards the apex, right? And that contraction actually pushes this tip of the apex of the left ventricle forward, and spiral fibers are also contracting. So not only the real mechanism is not only tip of the left ventricle moves forward, but it also rotates anti-clockwise. So what really happens, that it will move, number one, forward, number 1 forward, and number 2, or if you look at here, it will move number 1 forward, number 2 it will rotate anti-clockwise. If it is like this here, right, it will move like this. Here is chest wall, it will hit the chest wall and slightly move anti-clockwise, right, and it will keep on squeezing the blood as a closed chamber until aortic valve open. When aortic valve open, there is rapid ejection phase. Blood start going out of the ventricle to the aortic chamber, right? And when about 60%, 50% blood has been ejected, right, then pressure in the ventricle becomes less and this falls back and rotate back clockwise position to the medially. Again, I know it's a little confusing. It's worth repeating that when left ventricular systole start, initially left ventricle is contracting as a closed chamber as it closes the mitral valve first, right? First, and it keep on contracting until it builds up enough pressure to open the aortic valve. This early duration during which mitral valve has been closed and aortic valve is yet not open, this early phase where left ventricle is contracting as a closed chamber, this is called isovolumetric contraction. During this phase, longitudinal fibers which are running in the longitudinally, these are the deepest fiber of myocardium, and then they are a spiral. When longitudinal fibers contract, it shortens from apex to base, but with that it also kick forward the tip of left ventricle. So it kick forward and spiral fiber also contract. So not only tip of the left ventricle moves forward and hit on the back of the chest wall, interior chest wall, but it also rotate anti-clockwise. But when pressure become enough that it can open the aortic valve, rapid ejection start, right, and pressure here become less and it falls back and it rotates back clockwise, right. Now when it hit on the back of the chest, interior chest wall, that is what we palpate here, or in thin chested person we can observe or inspect that with every cardiac impulse. So this palpation, right, this is in early systole. In healthy person, it should not last more than half of the systole. It should be less than the half of the systole, right? It should be the early, because later on I will tell you that some other types of apex beat which are abnormal, right? Then what will happen, that apex beat you can palpate maybe throughout the systole, right? So normal apex beat, lowermost and outermost area of the precardium where a definite cardiac impulse can be felt, that is also called point of maximum impulse, right? And this point, right, is normal adult in mid-clavicular line in fifth intercostal space, usually less than 3 centimeter square, 3 centimeter square area, and in children it is slightly superior, usually in fourth intercostal space, and it can be best palpated when patient is lying in left lateral position, decubitus, and at the end of expiration. Is that right? Now, this was the mechanism and location of apex beat. There is a question. If left ventricular contraction is producing apex beat here, why right ventricular contraction does not produce apex beat? Because right ventricle also contract, and left ventricle and right ventricle both contract almost simultaneously. And interestingly, if this is left ventricle and this is right ventricle, they are in this position. Right ventricle is more, if this is chest wall, right ventricle is more with the chest wall and left ventricle is less. But when right ventricle contract, we don't feel, if right ventricle is healthy, we don't feel any beat here, right? Why? What could be the reason that when left ventricular systole, right, leads to production of apex beat, but why right ventricular systole or contraction does not lead to any palpable beat? The answer is that left ventricle is normally physiologically 3 times thicker than the right ventricle. Right ventricle wall is very thin, and right ventricle as compared to the left ventricle produces far less force because it has to generate less pressure. You know, the pressure fluctuations, systolic pressure in left ventricle can go up to 120, but systolic pressure in healthy right ventricle go up to just 25 millimeter of mercury, right? So because even though right ventricle is slightly more interior to the left ventricle, still right ventricular systole does not produce any palpable beat in a healthy normal person because right ventricular wall is thin, it produces less force, and it has to generate lower pressure as compared to the left ventricle, right? So what you really feel in left ventricle, the character of the impulse is that when you are feeling in fifth intercostal space in mid-clavicular line, usually you feel there's a gentle lift of your finger, palpating finger, right? And then heart or beat retracts back, and it is for very short time. As I told you, it is less than half of the systole or first 1/3 of the systole. In some pathological conditions, it may be lifted more, or it may be the apex beat duration become prolonged. That we will discuss when we will talk abnormal type of apex beat, right? Now, so this was something about the normal apex beat, right? Now we come to abnormal apex beat. One by one we will discuss first of all heaving apex beat, then thrusting apex beat, which is also called hyperdynamic apex beat, then the real difference between heaving and thrusting apex beat, and then later on we'll go for tapping apex beat, dyskinetic, double or triple apex beat, absent apex beat, retracted apex beat, and displaced apex beat. Now let me focus right now on the heaving apex beat. Heaving apex beat means what? First, a simple analogy. If, for example, this is the chest wall, and if heart come and hit here and go back, right, this is normal apex beat, the normal apex. But if the tip of the left ventricle comes and contraction is so forceful that it heaves, it lifts the area, right, where you are palpating for a while, what does it mean? That left ventricular contraction is stronger than normal. If left ventricular contraction is much stronger than normal, then it will hit the precardium more strongly, right? And it will elevate it for a while, right? And this elevation may last more than half of the systolic duration, right? This strong and prolonged character of apex beat leads to the classification of this apex beat to heaving apex beat. So what is heaving apex beat? Heaving apex beat is where apex beat is stronger than normal and more prolonged than normal, right? But question is, why in some patients there is heaving apex beat, right? Let me explain. Actually, let's go back to the left ventricle and let's talk to the left ventricle why it has to lift the apex beat area or produce heaving apex beat, right? Classically, this happens when there is pressure overload in the left ventricle. For example, let's suppose this is mitral valve is closed and there's onset of systole and left ventricle start contracting, right? And it is supposed to open the which valve? Aortic valve. Now, let's suppose due to some reason there is some outflow obstruction. As I told you, normally what happens that pressure, for example, when at the end of the diastole, when the ventricle is filled properly, it start contracting, early systole occur, pressure start building. In early pressure, this valve is closed. Then pressure keep on building and now it is pressure is going up as isovolumetric contraction until pressure in the ventricle become more than pressure in the aorta and this valve will open. But now we imagine that there is some resistance to the outflow, pathological resistance, or there is some obstruction to the outflow. Let me take a classical example, a patient with aortic stenosis. Let's suppose there is a person where aortic valve is thick and aortic valve is narrow and this has to generate more than normal pressure to open the aortic valve. If an aortic valve is stenotic, stenotic means that during the systole it is not opening fully as it should normally. So it is narrow. So if it is narrow or it is difficult to open, so what will happen? There is a resistance to the outflow for the intraventricular blood. Then to eject the blood outward or to open the aortic valve, now intraventricular pressure has to be more. And if this is a chronic condition, what will happen? That left ventricle will undergo, yes, hypertrophy. Left ventricle will undergo hypertrophy. So whenever there is chronic, we call this condition when there is more resistance to the outflow of the left ventricle and left ventricle has to pump stronger than normal, we say left ventricle is under pressure overload. What is the term? Pressure overload. So all those conditions, pathological conditions which produce pressure overload, left ventricle has to generate more pressure, and if these are chronic conditions, eventually left ventricle become hypertrophied. Most of the time this is concentric hypertrophy. This is concentric. Here I want to tell you the difference between concentric and eccentric hypertrophy. Concentric myocardial hypertrophy or left ventricular hypertrophy, and there is other condition which is eccentric. Now, concentric hypertrophy is when there is pressure overload and left ventricle keep on hypertrophying but without any significant change in its lumen, without any significant dilation, right? And in this case, left ventricular wall becomes thick. It becomes thick. And when left ventricular wall becomes thick and it has to contract strongly, what will you can easily understand. And what will happen? The tip of, during the systole, the tip of the hypertrophied left ventricle will hit the back of the precardium more strongly. And because there is obstruction, not only it will hit here more forcefully, but it has to take long time to get enough blood ejected. So here you will feel on palpation with your fingers that apex beat is not only more forceful, but it is also prolonged. It is more than half of the systole, right? And this apex beat is called heaving apex beat. So heaving apex beat is classically produced when there is any condition which is producing pressure overload chronically to the left ventricle. And I go back that in these conditions, usually there is concentric left ventricular hypertrophy in which left ventricle become thick, but there is not significant dilation and there is no significant change in the volume of the left ventricular lumen. But in some other conditions, as we will discuss later, in thrusting apex beat or some diseases where hypertrophy occurs, but also left ventricle dilates. If left ventricle dilates, then what will happen? Even though myocardial mass due to hypertrophy is more than normal, but because of the enlargement of the left ventricle, the thickness in a given area of left ventricle does not increase significantly, even it may thin out as compared to the normal heart. So that kind of hypertrophy where left ventricular dilation is there and lumen is getting larger as left ventricle is dilating, we call it eccentric left ventricular hypertrophy. Now, when there is concentric left ventricular hypertrophy, right, there is no dilation, or there is no significant dilation, or there is significant thickness of the chest wall. But when there is eccentric left ventricular hypertrophy, left ventricle dilates, lumen increases, and in a given area, left ventricular wall may not be significantly thick. Right? Now, we come back. In pressure overload, in the early time, let's suppose this is a patient with aortic stenosis. In early few years, left ventricle will keep on undergoing hypertrophy as stenosis become worse. It become more and more narrow. It keep on becoming more and more hypertrophied so that it can get enough blood out. And with the time, apex beat will keep on getting more and more heaving. Is that right? But eventually what will happen? That it cannot further hypertrophy. And whatever blood is coming, let's suppose 50 to 60% should be ejected. But resistance is so much, outflow resistance is so much that with all its might and power, it cannot get enough blood out, right? So it starts dilating. And when it will start dilating, what will happen? That this dilating heart is going towards the failure. That we will discuss in the next section, thrusting apex beat. Here I want to mention one more thing. Patients which have heaving apex beat, if you auscultate them, you will hear fourth heart sound very commonly. Why? Actually, when left ventricle is thick, then it is less compliant. There is some sort of diastolic dysfunction because when left ventricle is thick, during the systole, thick ventricle will produce more force. But during diastole, very thick left ventricular will not relax properly. It will not relax properly. So during diastole, when mitral valve open and blood should move from where? Atria to the ventricle. During diastole, if left ventricle is very thick, hypertrophied, and it does not relax well, then what will happen? That during the filling phase, there is undue resistance. Eventually, left atrium has to push the blood into ventricle with force, and eventually left atrium may also become hypertrophied. Normally when left atrium contracts, right, it contributes to about last 20% of the ventricular filling. About 70 to 80% of the ventricular filling is passive. Normally when left atrium contracts, the last 20% filling does not produce any sound. But when left ventricle is hypertrophied and it fails to relax, when 70 to 80% it is full, right, due to its smaller lumen, what happens? The pressure here is more. Now atria has to contract against higher pressure, and that will produce high velocity of blood moving from atrium to the ventricle under the strong atrial contraction, right? This strong atrial contraction is called atrial kick. Atrium is kicking in the ventricle. It is pushing, not throwing the blood or squeezing the blood. It is kicking the blood in the ventricle. And this turbulence produces fourth heart sound. So when you have a heaving apex beat, and also you can palpate the heaving apex beat, and you can auscultate S4, it is pointing towards what? It is pointing towards pressure overload. It is pointing towards hypertrophied left ventricle, right? Now, any question you have about aortic stenosis? There are, yes.
Are there some types?
Yes, there are there are many types of aortic stenosis, but at our discussion right now we should talk about two types of aortic stenosis. One is due to bicuspid aortic valve. Remember, normally aortic valve is tricuspid, but some people are born with bicuspid aortic valve. This is congenital abnormality, right? And other cause of aortic valve stenosis, which is common, that the common cause, especially when you are above 65 years of age, that is sclerotic aortic valve. Now, what is the real difference? Actually, here the person is born with bicuspid valve, but usually clinically he does not present in childhood. Why? Bicuspid aortic valve is not as efficient as tricuspid normal aortic valve, but still it is efficient enough in the beginning of the years, for 20 years, 30 years, depending upon, right, that it keep on working well. It is throwing the blood, but because of its bicuspid anomaly, the blood which is going through this valve, that passes through abnormal traction, and that produces damage to aortic valve chronically. Again, I will repeat it. Someone who is born with bicuspid aortic valve, someone who is born with bicuspid aortic valve, for early decades, 10 year, 20 year, even up to 30 year, 40, sometimes up to 40 year, they don't have any symptom or problem. But over so many years, when bicuspid valve is opening, closing, and it is not tricuspid, right? So blood is chronically damaging this abnormal configuration of the valve, and eventually this valve may undergo some sort of sclerosis. Some sort of sclerosis means hardening. It will undergo fibrosis, and eventually it becomes narrow. And when it becomes significantly narrow, then stenotic clinical features related with stenosis come, right? This type of problem usually become congenital bicuspid aortic valve usually becomes symptomatic before the age of 65. They are under the age of 65 years, of course. So if someone comes to you with aortic valve stenosis in the age of 30 year or 40 year, you must think of bicuspid aortic valve. You must think of bicuspid aortic valve. But sclerotic or calcific or degenerative, this is called sclerotic, or better word which is more commonly used, that is degenerative aortic valve, degenerative aortic valve, stenosis, right? This is also called calcific, degenerative or calcific. Now, this is not congenital anomaly. Person was born with normal aortic valve which was tricuspid. But over many years, it gets stenotic, damaged and stenotic. Usually, they become symptomatic after the age of 65 years. What could be the underlying cause? Now they have discovered the risk factor for degenerative aortic valve are almost same as the risk factor for atherosclerosis. That is why many patients with degenerative aortic valve stenosis also develop coronary artery disease because underlying risk factor are same. Atherosclerosis also has old age. Also, both of them are more common in patients with hyperlipidemias or with smoking or other sedentary lifestyle or many other risk factors which are associated with atherosclerosis. We will not discuss here, right? So what I'm saying, basically, we can imagine that actually degenerative aortic valve stenosis or calcific aortic valve stenosis, we can just think of as if a disease like atherosclerosis has attacked the aortic valve, endothelium or intima and produced stenosis rather than atheroma, right? So again, I will mention what is the most common cause of aortic valve stenosis. If patient is younger, the cause is bicuspid, congenital bicuspid aortic valve. If someone is very senior citizen with golden years, more than 65 years old, and aortic valve stenosis is now becoming symptomatic, most probably the most common cause in this case is going to be degenerative atherosclerosis or calcific atherosclerosis, and this patient might have other features related with advanced atherosclerotic disease, maybe coronary problem or maybe in some other vulnerable arteries, right?
Why we call it calcific?
Because calcification occur, as why we call it calcific, because even atheromas, they also undergo calcification. In the same way, here what happens that if the same risk factors are there, maybe here also endothelium is damaged, here also macrophage go in, take the lipid with them, and growth factors are produced, lot of inflammatory factors, inflammation inducing chemicals are produced, and this chronic inflammatory condition here damages a lot of tissue, and cells which degenerate here, their cell membranes open up. When their cell membranes, damaged cell membrane open up, they have phospholipid. Phosphate are negatively charged and calcium is positively charged. So calcium will start depositing there. That is it. Okay. Then we come to another type of problem which is producing pressure overload and heaving apex speed. One cause is, up to now we discussed, one cause was aortic stenosis. Now, second cause is systemic hypertension. Systemic hypertension. If someone has systemic hypertension, it means that total peripheral resistance on the systemic arteries is high and left ventricle has to contract more strongly. Patient with systemic hypertension, where blood pressure is more than normal, systemic blood pressure, then left ventricle has to contract more strongly during every systole, and eventually it becomes hypertrophied. And when it becomes hypertrophied, remaining mechanism, that hypertrophied left ventricle will hit the back of the precardium, right, more strongly, and that will produce heaving apex speed, right? But here I want to mention one thing very clearly. Pulmonary hypertension does not produce heaving apex beat. Pulmonary hypertension produces left sternal heave or left sternal lift, because in pulmonary hypertension there is basically hypertrophy of the right ventricle. Let me explain that. Let's suppose here is your beautiful heart, I hope so, and this is right side going to the lungs, and from the lungs blood is going to the, here I'm putting, even though they are together, but putting left ventricle little bit separate. Now if there is systemic hypertension, pressure is here and left ventricle undergo hypertrophy. But if there is resistance to outflow to the right heart, for example, there is pulmonary stenosis, or there is mitral valve stenosis, because patient with mitral valve stenosis has high, what is this, pressure in the left atrium, then back pressure increases into pulmonary vein, pulmonary capillaries, and eventually pulmonary arteries, right? So either pulmonary valve, suppose stenosis, or mitral valve stenosis with back pressures going and eventually leading to pulmonary arterial hypertension. That will lead to hypertrophy of the right ventricle. Now right ventricle is of course on the right side, and that is on the just on the back of sternum. And what happens when pulmonary hypertension is there, right ventricle will get hypertrophied, and then it will lift the which area? Left sternal area, right? So we can put our hand over here and we'll see with every beat it's slightly lifted up, right? This is actually right ventricular hypertrophy producing left sternal heave. Don't call it right sternal heave. It is on the left side of the sternum, but under it heave is being produced by hypertrophic right ventricle, right? So don't confuse heaving apex beat with right parasternal heave. Right parasternal heave. No, this is left parasternal heave. You are right. This parasternal heave is due to right ventricular hypertrophy, but heaving apex beat is due to pressure overload or hypertrophy of the left ventricle. Now we have discussed about aortic stenosis. We have also discussed about systemic hypertension. Okay, one more cause. Now we'll at least I should discuss two more causes, even though there are many causes. One cause I would love to discuss is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy. Now hypertrophic cardiomyopathy, right? What happens in this case? Underlying problem is genetic. There is some genetic defect in the myocardial system, and with the time myocardium become hypertrophied. And if myocardium becomes hypertrophied, especially in this area, what is this? Septum. If hypertrophic cardiomyopathy produces septal hypertrophy, but remember it can produce hypertrophy anywhere or all of it. But if it produces septal hypertrophy, the blood which want to go out will have outflow obstruction, right? This can also produce heaving apex beat. But later on we will discuss that this can also produce double apex beat or triple apex beat. That we will discuss later, right? But one thing which I want to mention at this stage, that if there is patient with hypertrophic cardiomyopathy, especially if there is septal hypertrophy, that also produces left ventricular outflow obstruction, and that can also lead to, when it is forcing for longer time and with more strength, it will produce heaving effect in the apex beat area, right? But remember one thing, previously, for diagnosis of hypertrophic cardiomyopathy, we were specially looking for septal hypertrophy. Now, actually, recently, they have reclassified this condition. They say any part of left ventricular wall, any part of left ventricular wall, if it is thicker than, it is more thick than 1.5 centimeter on, of course, echocardiography. Any part of left ventricular wall is thicker than 1.5 centimeter or more than 15 millimeter, that is one and the same thing, right? It should be classified as hypertrophic cardiomyopathy, right? So it is now, they say it is not necessary that there should be septal hypertrophy present. Many a times, many patients come across with hypertrophic cardiomyopathy. There you see hypertrophy in some other areas of left ventricle, but not in septum. But usually this hypertrophy is not concentric or eccentric, it is asymmetric hypertrophy, right? We will discuss that later. Here I want to say one thing also. If hypertrophic cardiomyopathy has this hypertrophy of septal area, it is subclassified as hypertrophic obstructive cardiomyopathy. Hypertrophic obstructive cardiomyopathy. Many of these patients are they have inheritance, autosomal dominant inheritance. We will have a full lecture separately on it, right? For a while, one thing you need to remember about this disease: they have a risk of sudden death. In hypertrophic cardiomyopathy, especially hypertrophic obstructive cardiomyopathy, usually sometimes they undergo sudden death, especially young men. We see young athlete who is running or doing some athletic activity or extreme exertion. Maybe that precipitates severe outflow obstruction, because when left ventricle during exercise is pumping too much, tachycardia. Tachycardia is reducing the diastolic time. It is filling less, and because heart during exercise is hyperdynamic, it is becoming too much in front of it. Obstruction is being enhanced during tachycardia. Then less blood is going out, less blood going to the coronary. Ischemia may start, chest pain may start, or arrhythmias may occur. So syncope may occur. So these conditions may lead to, if they are excessive, sudden cardiac death in patient with especially young male during athletic activity. But please don't confuse this kind of hypertrophy with athletic hypertrophy. Most athletes which do significant exertion, their heart undergoes somewhat hypertrophy, right? But that hypertrophy is within physiological limits, and there's no underlying, you can say, genetic abnormality, right? This is an unusual condition, hypertrophic cardiomyopathy. This should be differentiated from other types of hypertrophies of left ventricle, which are, for example, hypertrophy of left ventricle due to systemic hypertension is different, or hypertrophy of left ventricle due to aortic stenosis is different than cardiomyopathy, right? Then I come to the one more condition, yes, coarctation of aorta. This is very interesting condition, thank God not very common. This is a congenital condition, coarctation of aorta. What really happens here is that this thoracic descending part of aorta has narrowing. It has narrowing. And so blood is going, but there is some obstruction also, right? And usually this coarctation or this narrowing of the aorta is distal to the, what are these arteries? This is right subclavian, and here is left subclavian. This coarctation is, okay, pathological region, This coarctation is narrowing is usually distal to the both subclavian arteries, right? And it produces very unusual type of clinical findings. What will happen here? When left ventricle contract, number one thing is there, of course, there is obstruction to flow. So eventually it will become hypertrophied and it will again produce, it undergo pressure overload, and again it will produce what? Heaving apex beat, right? So it is also one cause of heaving apex beat, coarctation of the aorta, right? But this produces one thing. It reminds me a few interesting things about it. Number one, it is coarctation of aorta is very important cause of secondary hypertension or hypertension of young people, because when left ventricle has more resistance to push the blood through the aorta, it will hypertrophy and it will generate more pressure. So more pressure will be pushed into aorta. But as there is obstruction, pressure in this area is more, and both arm and all arteries before the coarctation will have higher pressure. So in these patients, if you take blood pressure from the arms, there will be higher pressure. But if you take blood pressure from the legs, that is low. So if there is arm blood pressure is high and leg blood pressure is low, you should suspect coarctation of aorta. Coarctation of aorta, yes.
Are we talking about the systolic or diastolic blood pressure?
Okay, she's asking that, blood pressure which is elevated in upper limb, right, and not elevated in lower limb or less than normal in lower limb, this difference is systolic or diastolic. Answer is, actually, this is the left ventricle when it contracts. During the systole, it pushes the extra blood, blood with extra force. But this blood with extra force is going to the upper part of the body and to the arms, right? And this pressure is generated by systole, right? So, but systolic pressure is not faithfully conducted down to the legs because of this narrowing. So this is the systolic blood pressure which is elevated in upper limbs, and it is the systolic blood pressure which is low in the lower limbs.
So then what about diastolic?
And what about diastolic? Diastolic pressure in upper limb and lower limb was still almost equal. For example, in upper limb, blood pressure may be upper extremity, right? Blood pressure will be 150 or 150 by, let's suppose 90. But in lower limb, you will find 110 by about 90. Now, why diastolic is almost equal or equal? The reason being, diastolic blood pressure depends on peripheral resistance, right? Diastolic blood pressure mainly depends on the peripheral resistance. Peripheral resistance is mainly offered by arterioles, and arterioles in the arm and arterioles in the legs are offering the same resistance to the blood flow. Because they are offering the same resistance, so diastolic blood pressure is same on both sides. But when left ventricle contract, right, then more blood under higher pressure is transmitted during left ventricular systole. More blood with higher, I can say, pressure is pushed more to the upper limbs than the lower limb. So that leads to a systolic significant elevation in upper limb as compared to the lower limb. Another interesting finding in this condition is that radiofemoral delay. If you simultaneously palpate femoral artery and radial artery, of course you have two hands. So remember, one pulsations here, another pulsations you are checking here. They will not be almost simultaneous. Radial pulse or brachial pulse will be earlier than femoral, or more true wording should be radial pulse or brachial pulse, right? Right? They are actually in their own time. There is delay in the femoral due to this obstruction and slow flow. So there is radiofemoral delay or brachiofemoral delay. But here what we were discussing, heaving apex beat. So we discussed mainly whenever you have apex beat which is stronger than normal and
Sustained.
prolonged, strong and prolonged, and maybe slightly, usually it is small, localized within 3 centimeter if it is not dilated heart, and usually it is at its normal position, or if there is significant hypertrophy with little dilation, maybe it is pushed downward and leftward, right, inferiorly, and you can say away from the midclavicular line, but not as much as we will see in next session in thrusting and hyperdynamic, where you can say there's a big change, very big difference between features of heaving apex beat and thrusting apex beat. And of course, the underlying mechanisms and causes of heaving apex beat and thrusting apex beat are very different, and every clinician should know how to differentiate between heaving apex beat and thrusting apex beat, as underlying mechanisms are very different. Right now we just discussed heaving apex beat. There are many causes, but I just discussed basic mechanism that in heaving apex beat, stronger and prolonged apex beat is there, right? Usually surface area of the apex beat is not significantly large, there is no significant displacement, and underlying causes there is pressure overload on the left ventricle, which is and left ventricle is hypertrophied, right? Classical causes you must know at least two: aortic stenosis and systemic hypertension. And in aortic stenosis, even though in the third world, still one of the common causes rheumatic heart disease, which is, but especially in the first world, if you are under the 65 years old and disease becomes symptomatic in the age of 40-50, think of bicuspid aortic valve stenosis. But if you are 70 or 80 and then aortic stenosis becomes symptomatic, think of degenerative aortic stenosis. Then we talked about systemic hypertension, then we talked about hypertrophic cardiomyopathy, and in the end we talked about coarctation of aorta. And there are many other causes also for outflow obstruction. Next session we'll discuss in detail causes and the underlying mechanism of thrusting apex beat and how you can differentiate heaving apex beat and thrusting apex beat from each other. Thank you.